Hi, my name is Sanar Siotish, and today we're going over my CE called Tight Control, and it is about the 2017 hypertension guideline updates. So, at the end of this presentation, all participants should be able to describe the 2017 ACC/AHA guideline updates, understand the rationale behind the 2017 guideline updates, appropriately place patients in the correct blood pressure category, and create an appropriate treatment regimen for patients with hypertensive emergency or urgency. So hypertension obviously has a huge impact in the United States. So hypertension by itself was the primary contributing cause of death for more than 410,000 Americans in 2014. That roughly equates to about 1,100 deaths per day. And according to the CDC, about 75 million people have hypertension. And of those 75 million people, only about 54% of them actually have their hypertension under control. Morbidity and mortality is more common in African American and Hispanic adults compared to Caucasians, and just some reasons for that might be simply due to socioeconomic status and better access to healthcare. So, what is the prevalence of hypertension? So, prevalence of hypertension was 29% according to the 2015-2016 National Health Nutritional Examination Survey. And as you see, if we could break down the prevalence of hypertension by race, you can see the non-Hispanic blacks, as I mentioned before, have the highest prevalence of hypertension with 40.3% compared to non-Hispanic Asians who have the lowest amount at 25%. And then next we'll talk about the prevalence of hypertension by age. And as you can see, there's obviously the older you get, the more likely you are to have develop hypertension. And you can see as once you hit 40, there's a huge and dramatic increase in the percentage of prevalence of hypertension by age. And once again, when you reach 60 or above, there's another huge dramatic increase as well. So here's a nice graphic about the prevalence of hypertension in 2017 for U.S. adults ages 20 years or older. And it kind of just breaks down the prevalence of hypertension by each state. So kind of want to draw your attention simply to the Midwest and down south. As you can see, these areas have the highest prevalence of hypertension, and just some reasons might be due to obesity, as these states have higher obesity than the rest of the country as well, and that is a risk factor for hypertension. And then if you bring your attention to Michigan, where we live, you can see the prevalence of hypertension is anywhere from 30.1 to 31.9%. So what are the outcomes of hypertension? Of uncontrolled hypertension. So about 7 out of 10 people who experience their first heart attack have hypertension. 8 out of 10 people experiencing their first stroke have hypertension. And 7 out of 10 people with chronic heart failure also have hypertension. So obviously this puts a great burden on the healthcare in the United States. So hypertension by itself costs the nation $55.9 billion each year, while total adjusted cost is $131 billion. So total adjusted cost accounts for missed work days as well due to hypertension, which explains why there's a huge drastic increase as well. And then simply reducing dietary sodium intake by almost 1 gram can actually decrease hypertension cases by 11 million annually, and that can save up to $18 billion a year, and that's billion with a B. And then annual medical expenditure attributable to a patient with hypertension is about $9,089. So first, we'll go over the first learning question. So true or false? Hypertension is not prevalent in Michigan. I'll give you guys a little time to go over it. Okay. And the correct answer, sorry about that, the correct answer is actually false. So if you remember correctly, the prevalence of hypertension in Michigan is anywhere from 30.1 to 31.9%. So why are there new changes to the guidelines? So new evidence from landmark trials and their sub-studies, such as the systolic blood pressure intervention trial, or something known as the SPRINT trial, hypertension in the very elderly trial, or the HIVIT, action to control cardiovascular risk in diabetes, or the blood pressure accord trial. And there's also new guideline up changes include modified blood pressure ranges and treatment recommendations based on prior history of CVD and ASCVD risk as well. So first we'll start discussing the SPRINT trial, which is pretty much the precursor to the new guideline updates. It's kind of set the tone for all the recommendations. So the SPRINT trial, the objective of it was to compare CV outcomes with patients with increased CV risk. There's about 9,000 subjects enrolled into this study, and inclusion criteria was greater than or equal to 50 years old with increased CV risk, systolic blood pressure of 130 to 180, and if they were on 4 or less antihypertensive medications. Patients were excluded if they had a history of stroke or diabetes, symptomatic heart failure or heart failure with an EF of less than 35%, severely elevated blood pressure, meaning greater than 180, orthostasis, and nursing home patients. Patients were either randomized to the intensive blood pressure group, which was less than 120, or the standard blood pressure goal of less than 140. But however, the overall study's goal was blood pressure of less than 130. So the primary outcomes of the SPRINT trial included first ACS, stroke, heart failure, or CV death. The results were the intensive group had an average blood pressure of 121 versus 135 in the standard group. There's a 25% risk reduction of primary composite endpoints for the intensive group, and this had a huge impact. So one, like I mentioned before, was the precursor and kind of changed the definition of the blood pressure ranges. All the blood pressure ranges come from this study pretty much, and also provided guidance for treatment of hypertension based on prior CVD and ASCVD risk as well. So they also had a sub-analysis, which they call the SPRINT sub-analysis 75 years and older. The objective of this was pretty much to see the necessity of intensive therapy in geriatrics. The population was 80 years or older, with an average blood pressure of 142 over 71, and patients were either randomized, patients were either classified as fit or less fit as well. And the way they did that, they used the frailty index to classify patients. So the primary outcome was there was a 34% lower in the intensive arm than the standard group. The less fit group had a reduction of the primary composite outcome with intensive therapy, and the less fit and fit groups had less all-cause mortality with intensive treatment as well. So, and then however, the fit group had the patients who were classified as the fit had no benefit with intensive blood pressure reduction as well. And just one thing to mention about the primary outcome too, improvement in this study was there's one of the critiques of the study. Improvement, like the main study, was kind of actually driven by the reduction of heart failure than any other CV risk factor or condition. So they found no difference in adverse outcomes and events. This kind of supported more intensive control in older patients as well, and it kind of set the precedent for aggressive treatment in older patients, even if they were frail or less fit. Next, we'll kind of go over the hypertension in the very elderly trial, or the HIVIT trial. So this kind of pretty much added more to the previous trial. The SPRINT sub-analysis kind of agreed with it, but we'll go discuss it and you'll see. So objective of this was to evaluate the occurrence of fatal or non-fatal stroke in adults with a baseline systolic blood pressure of greater than or equal to 160. The population was about 3,845 adults, and none of those patients were actually in the U.S. The inclusion criteria was 80 years or older, baseline systolic blood pressure of greater than or equal to 160. Patients were excluded that had CHF requiring an ACE inhibitor or diuretic. If they were terminally ill, they had secondary hypertension, gout, dementia, and medication contraindications as well. Patients were randomized to either indapamide plus perindopril or placebo. And the target goal blood pressure was less than 150 over 80. Oops. And then so the primary outcome was non-significant. However, they did find that there was a 39% reduction in death from stroke, 21% reduction in all-cause death, 74% reduction in heart failure, and 34% reduction in the occurrence of any CV event as well. So the conclusion was it supports targeting a blood pressure goal of less than 150 over 80 in patients 80 years or older, and the impact, like I mentioned before, further supported aggressive treatment in the geriatric population. Next, we'll discuss the CORD BP trial. So just a little inference about this. This was the BP arm from the CORD trial. So just some background information about the CORD. So the CORD trial was about type 2 diabetics and wanted to see if tight glycemic control was better than just standard care. And what they found is that actually tight glycemic control is not recommended. It actually does more harm than good. It's only good for certain individuals. So now going back to the CORD BP trial, so the objective was the effects of intensive blood pressure control versus standard control on CV outcomes in type 2 diabetics. So the population was 4,773 patients with long-standing type 2 diabetes. Once again, patients were randomized to either intensive blood pressure group of less than 120 or the standard blood pressure group of less than 140. The results were the intensive treatment of blood pressure does not actually improve CV endpoints despite better improved BP values. And what they found, the conclusion was that intensive therapy is not recommended in type 2 diabetic patients without a CVD risk as well. So one thing I want to mention about this is that they actually have their own, type 2 diabetics have their own special blood pressure category, and you'll see later on It's completely different than anybody else's. Their blood pressure goal is less than 140/90 compared to everybody else's, which is pretty much less than 130/80. And now let's to go over the classification of blood pressure. And once again, I'll like to reiterate that pretty much all these blood pressure goals came from the sprint trial, and it's kind of like set the tone of the whole entire guideline itself. So for normal, you just want a systolic blood pressure of less than 120 and a diastolic blood pressure of less than 80. For elevated, it's anywhere from 120 to 129 and less than 80 for the diastolic. And I just want to draw your attention, since we were talking about elevated, this took the spot of the pre-hypertension state. The guideline no longer uses that term. It's now just considered elevated. So for hypertension stage 1, it's 130 to 139 or 80 to 89 diastolic. And hypertension stage 2, it's greater than or equal to 140 for the systolic or greater than or equal to 90 for the diastolic. So you can see that these are classification of blood pressure goals are actually a lot more stringent than the previous guidelines, and that pretty much means that we're actually going to have more patients diagnosed with hypertension. However, most patients can prevent hypertension-related health problems just simply through lifestyle changes. Okay, and then learning question 2. SD is a 66-year-old white male with a past medical history for hyperlipidemia, hypertension, and type 2 diabetes. What is the blood pressure goal? What blood pressure goal is appropriate for SD? I'll give you guys a little bit of time to go over that. Okay, so answer choice A was less than 130/80. Answer choice B was less than 150/90. C was less than 140/90. And D was less than 120/80. So the correct answer choice is C. For, like I mentioned before, based on the CORD BP trial, we found that it's actually intensive blood pressure control is not very beneficial in type 2 diabetics without any comorbid conditions, and they type 2 diabetic population by themselves have the least stringent blood pressure goal. So hypertensive crisis, emergencies, and urgencies, these are definitions. There's actually no change in the guidelines for these definitions, so I'm just going to quickly go over them. So hypertensive urgency is greater than 180 and or greater than 120 for the diastolic. For hypertensive urgency, it's greater than 180 with target organ damage for the systolic, or greater than 120 for the diastolic with target organ damage as well. So here's kind of like a summary slide, just showing the evolution of how the guidelines have evolved. So first we'll start with the JNC7 in 2003. So their blood pressure targets was less than 140/90, and then it was less than 130/80 for diabetics, and if somebody had CKD. So their classification was for normals less than 120/80. For pre-hypertension, it was 120 to 139 and 80/89. 80 to 89, excuse me. Stage 1 hypertension was for the systolic was anywhere from 140 to 159, and the diastolic was anywhere from 90 to 99. And for stage 2 was greater than or equal to 160 for the systolic and greater than or equal to 100 for the diastolic blood pressure as well. So it kind of, if you just draw your attention to the very bottom of the chart, you can see that how less lenient and more stringent the new guidelines are compared to the JNC7 in 2003. And then in 2014, the JNC8 guidelines came out, and their recommendations were less than 150/90 for patients greater than or equal to 60, less than 140/90 for patients less than 60, and if they had diabetes and CKD. A couple issues with the JNC8 was that it was not a comprehensive set of recommendations and did not discuss hypertension diagnostic thresholds compared to the JNC7. And in 2017, actually right before the ACC/AHA guidelines came out, the American College of Physicians and the American Academy of Family Physicians came out with their own guideline, and their recommendations were less than 150/90 for patients greater than or equal to 60, and then less than 140/90 for patients with a higher CV risk or a history of TIA or stroke. Once again, this guideline had a couple of issues with it. Once again, it was not a comprehensive set of recommendations and did not discuss hypertension diagnostic thresholds. And you'll notice one other thing, it doesn't actually have any recommendations for patients less than 60 as well. And then once again, in 2017 came out the AC/AHA guidelines, and when that guideline came out, the ACP/AAFP guidelines actually did not support the new guidelines, and they chose not to retract their guidelines. So the ACP/AAFP guidelines should be considered a current and active set of recommendations. Most facilities probably don't use it, but if you do run into them, they are considered active recommendations. So learning question 3. Jay-Z is a 56-year-old white male that comes into the clinic for a routine visit. Jay-Z's 2 blood pressure readings were as follows: 135/83 and 136/85 respectively. What is the correct category classification for Jay-Z's blood pressure? It's either A, normal, B, elevated, C, stage 1, or D, stage 2. I'll give you guys a little time to go over it, and then we'll go over the correct answer. Okay, so the correct answer choice is C, stage 1, and the reason stage 1 is if you look at the systolic blood pressure, it ranges anywhere from 130 to 139 for both readings. Therefore, the patient's classified stage 1 based on that, and the diastolic isn't above 90 as well. So we'll go over treatment recommendations. And so with the new guidelines, there's a huge emphasis on cardiovascular disease and risk as part of staging and treating. So they actually came out with their own ASCVD risk calculator, which assesses a patient's 10-year ASCVD risk. So just for example, if the calculator says someone has an ASCVD is 10%, that means the patient has a 10% chance of having an ASCVD event within the next 10 years. So the ASCVD calculator incorporates age, sex, race, blood pressure, both systolic and diastolic, and if whether they're on any medications, if they're diabetic, if they have hyperlipidemia and whether they're on a statin or not, smoking status, whether there's current, former, and how long ago they quit, and whether they're on aspirin therapy. So learning question 4, NC's ASCVD risk calculator score is 15%. What is the likelihood of him having an ASCVD event within the next 10 years? So if you think it's A, 5%, B, 10%, C, 15%, or D, 20%. Once again, I'll give you guys a little time to go over this. Okay, so the correct answer choice is C, 15%. So pretty much when the calculator gives you a score of 15%, just means you have a 15% chance of having an ASCVD event within the next 10 years. Pretty straightforward. Okay, so once again, we'll continue with the emphasis on cardiovascular disease. So they kind of break it down into primary prevention and secondary prevention. So primary prevention is concerned with preventing the onset of disease, while secondary prevention tries to reduce the number of new or severe cases of the disease itself. Some things for secondary prevention will be CAD, CHF, or a CVA as well. So we'll start with primary prevention, recommendation for primary prevention. So if a patient has no history of CVD and an ASCVD risk less than 10% and a blood pressure of greater than or equal to 140/90, the treatment's actually 2 blood pressure lowering medications plus lifestyle changes as well. So one thing you'll notice is with the new guidelines, that's stage 140/90. Greater than that is considered stage 2, and the guidelines actually recommend starting 2 medications right away, compared to previous guidelines which actually only emphasize starting with 1 medication and then reassessing within 3 to 6 months whether new medication needs to be added or not. However, that is no longer the recommendation. You want to start with 2 right away. Another thing for primary prevention is if they have an estimated ASCVD risk of greater than or equal to 10% and a blood pressure greater than or equal to 130/80, you want to use 1 blood pressure lowering medication plus lifestyle changes as well. Obviously, you're more likely going to add a statin as well, or some hyperlipidemia lowering medication as well. And then for secondary prevention, so it's pretty much a recommendation of the clinical CVD and a blood pressure greater than or equal to 130/80. You once again want to use 1 blood pressure lowering medication and lifestyle changes as well. And you're more likely going to add a cholesterol lowering medication as well. So now we'll discuss the first-line antihypertensive drug classes. So we'll first start with ACEs and ARBs. So potential population is for the younger population and Caucasians, and the reason for that is they actually have increased RAS activation compared to other populations. Just some considerations: cough is more common in Asians. African Americans are more likely to develop angioedema. Some contraindications or disease states not to use ACEs or ARBs are AKI, bilateral renal stenosis, pregnancy, and hypovolemia. On the Ascension formulary, we have enalapril, enalaprilat, lisinopril, and losartan. And then for calcium channel blockers, the preferred population is African Americans, or the potential population is African Americans. Some considerations: you can combine thiazide diuretics for African Americans of stage 2. Some contraindications are AV block and bradycardia for the non-DHP calcium channel blockers. hypertrophic obstructive cardiomyopathy for DHP, calcium channel blockers, and you don't want to use any calcium channel blockers in ACS. Just some medication we have on formulary are amlodipine, diltiazem, nifedipine, and verapamil. And once again, for thiazide diuretics, you can use it in African Americans, and you can also combine it with calcium channel blockers if they have stage 2. So the guidelines actually say hydrochlorothiazide is least effective thiazide, and they actually don't prefer it. They prefer chlorothalidone. Even they understand that most physicians, it's a very popular drug, and it's a very cost-effective drug, but however, they really don't recommend using that for blood pressure control. So just some contraindications are hypokalemia, renal failure, lithium treatment, and gout. And we have on formularies hydrochlorothiazide, chlorothalidone, and metazolone as well. So these are the fourth-line antihypertensive drug classes. So we'll start with the mineralocorticoid antagonist or the potassium-sparing diuretics, however you want to classify it. Just so the potential population for those are hypokalemic, they have reduced heart failure, proteinuria or edema. So you can combine, if the patient has proteinuria, you can combine with ACEs or ARBs. That's shown us to be reduced proteinuria. So according to the guidelines, spironolactone is actually better for resistant hypertension than eplerenone. And just some contraindications are hyperkalemia, obviously, if they have metabolic acidosis, acute renal failure, and gynecomastia as well. And we have formularies, as I mentioned, we have eplerenone and spironolactone. For beta blockers, you want to use in reduced heart failure if they have an MI, AFib, tachycardia, migraine prophylaxis, or tremor. Some contraindications are AV block, decompensated CHF, bradycardia, or asthma. And when we have on formularies atenolol, bisoprolol, carvedilol, metoprolol, or propranolol. For alpha blockers, you can use it for patients that have both hypertension and BPH, or ED, or PTSD, or nightmares as well. Just something to consider, it does cause, or these medications do cause orthostatic hypertension, so they may not be good for the elderly population. These are contradicted in CHF or pericarditis, and we have doxycycline on formulary. For vasodilators, specifically talking about hydralazine, it can be used for reduced ejection fraction with in combination with nitrates. A couple issues is adherence problems because these medications are 3 times a day. They can cause drug-induced lupus, increased BP variability, and reflex tachycardia. Some contraindications are CAD or SLE as well. And like I said before, we have hydralazine. The next one's minoxidil, and it's pretty much only used for very resistant hypertension. It causes profound salt and water retention, so it actually might not be a very good drug to use if a patient has heart failure. It is on the list of medications that can cause an exacerbation of heart failure, just so you guys are aware of that as well. It is conjugated in pheochromocytoma. And then next we have the central alpha-2 agonists. These can be used in combination with patients that have hypertension and anxiety disorders or ADHD as well. So they do cause anticholinergic effects, so might not be good medications to use on the elderly population. They can also cause rebound hypertension and bradycardia with blood pressure, with beta blockers, excuse me. Some contraindications are liver disorders with methyldopa and hypotension. And what we have is clonidine and methyldopa on formulary. So we'll go over now some couple of disease states and how to optimize the blood pressure. So we'll start with diabetes since it's the special one and is the least stringent blood pressure goal. So their goal is less than 140/90. You can pretty much use any antihypertensive of your choice. They're all pretty much effective unless there's contraindications, obviously. And you can consider an ACE or an ARB as first line in the presence of albuminuria as well. Now we'll go to CKD is a blood pressure goal of less than 130/80, and so does every single pretty much disease state after that as well. So I'm not going to keep repeating that. So for stage 3 or higher CKD, an ACE inhibitor is recommended. Stage 1 or stage 2 CKD with albuminuria, meaning they have more than 300 milligrams per day, ACE inhibitor is reasonable to slow the progression of kidney disease. For heart failure, if they've preserved heart failure with symptoms of volume overload, you actually want to use diuretics first to control hypertension, and then you can start adding ACE or ARBs and beta blockers for additional benefit. And then stroke or TIA, actually the selection of drugs is based on other comorbidities first. And for those who have an ischemic stroke and no previous treatment of hypertension, there's actually no evidence of treatment benefit. Their blood pressure goal is less than 140/90. And then for chronic aortic insufficiency, you kind of want treatment of systolic hypertension is reasonable with agents that actually do not lower heart rate, so pretty much you want to avoid beta blockers. Now we'll go over make it more something more for you guys since you guys in the hospital setting. We'll go over hypertensive urgency and emergency and a couple of disease states and how to treat those. So once again, hypertensive urgency is blood pressure greater than 180 over 120 without any signs of target organ damage. Treatment considerations are either reinstituting or intensifying oral antihypertensive drug therapy. There's actually currently no evidence that shows improvement of clinical outcomes with immediate reduction of blood pressure, so there's no need to use IV medications for these patients. And this commonly includes non-compliant patients or patients presenting with hypertension for the very first time. And another thing the guidelines recommend is actually screening for anxiety disorder, just to make sure that that's not the issue why their blood pressure is elevated. Now we'll go over hypertensive emergency. So this is defined as a blood pressure goal of once again less than greater than 180 over 120 with signs of target organ damage as well. So systolic blood pressure should be actually reduced by no more than 25% within the first hour. And the reason why you want to reduce it by no more than 25% within the first hour because greater reductions are actually associated with induction of cerebral ischemia as well. And in addition to that, if there's any neurological deterioration during the first 25% drop, therapy should actually be discontinued as well. And then within the next 2 to 6 hours, you want to kind of get it to 160 over 110. And then after that, you want to reduce cautiously to normal during the next 1 to 2 days as well. For severe preeclampsia or eclampsia or pheochromocytoma crisis, systolic blood pressure should be lowered to less than 140 during the first hour. And then for aortic dissection, you want to lower it to less than 120 during the first hour as well. So we'll discuss a couple of we'll go over some hypertensive emergencies. So start with acute coronary syndrome or ACS. So ACS is a condition associated with sudden reduced blood flow to the heart, such as an MI. Since some beta blockers that you can use are labetalol, esmolol, or metoprolol. So aortic dissection actually occurs when the innermost layer of the aorta is damaged. It kind of allowing blood to enter the aortic wall, causing the layers to be pulled apart. There's two types. There's type A and type B. Type A occurs in the ascending aorta, so A for ascending, and type B occurs in the descending aorta as well. So one thing to know is that type A dissections are usually actually an emergency and require surgical interventions, while type B dissections may be managed without surgery by carefully actually controlling the blood pressure itself. So due to shear stress, the treatment goal is actually twofold. So you want to control blood pressure and heart rate. For control blood pressure and heart rate, so you want to, like I mentioned before, you want to drop the blood pressure to 120 or less within actually the first 20 minutes if possible. The guidelines say within an hour, but from general practice, try to get in within the first 20 minutes. And then for heart rate, you actually want to try to get it 60 beats per minute within a couple of minutes after the diagnosis, if possible. Just some medications that could be used is labetalol. Obviously, that works on both controlling the blood pressure and heart rate, so that's why it can be used as monotherapy. Or you can use esmolol or metoprolol plus a vasodilator. If you're using a vasodilator such as nitroglycerin, this can cause actually reflex tachycardia, which actually increases the shear stress on the aorta. So it's something to be aware of. And also, if you're using this combination, you want to initiate the beta blocker before the vasodilator due to the beta blocker's slower onset relative to the vasodilator. And then you can use nicardipine plus esmolol, but there's some issues with this, such as risk of reflex tachycardia, and infusion can lead to large volumes administered as well. Next, we'll discuss an ischemic cerebral vascular event. So in an ischemic stroke, you want to reduce blood pressure to below 185 or 110 before initiating thrombolytic therapy. After thrombolytic therapy, the goal of blood pressure is less than 180 over 105, and this has actually been shown to have less intracerebral hemorrhages. And this is the goal during a reception of TPA and within 24 hours after as well. And then for those not receiving TPA, the AHA recommends actually withholding antihypertensive therapies unless systolic blood pressure is greater than 220 or the diastolic blood pressure is greater than 120 as well. And then just one thing to note as well for if their blood pressure is below 220 over 120 and they're not a candidate for receiving TPA, you don't want to restarting blood pressure treatment within the first 48 to 70 hours post-acute ischemic stroke is actually not effective, so you kind of want to wait after that as well, just to get more perfusion to the brain. And then general practice is to push labetalol first and then start nicardipine drip to prevent rebound hypertension. So next we'll discuss hemorrhagic cerebrovascular event. So the gold standard is surgery over medical therapy alone. So common medications, are nicardipine, clevidipine. Just a couple things to know about clevidipine. Caution with patients with soy or egg allergy, and or the oil and water formulation provides 2 lipid calories as well. And clevidipine is also restricted to the ER and the ICUs as well. Other medications are labetalol and phenoldiprate. Learning question 5. NL is a 56-year-old white female who presents to the ER with a blood pressure reading of 220/110. NL exhibits confusion, shortness of breath, and has chest pain. After examination, the patient is diagnosed with an aortic dissection. NL's home medications include lisinopril, 20 mg QD, amlodipine, 5 mg BID, and hydrochlorothiazide, 12.5 mg every day. What should the systolic blood pressure be reduced to within the first hour? So it's either A, less than 120, B, less than 130, C, less than 140, or D, less than 150. So I'll give you guys time to think about that, and then we'll go over the answer. Okay, so the correct answer choice is A. You want to get a blood pressure goal, a systolic blood pressure goal of less than 120 within the first 20 minutes as possible, and you also want to get the heart rate down within to 60 beats per minute within the first couple of minutes after the diagnosis of an aortic dissection. So learning question number 6, it was kind of a piggyback off the previous case. So what appropriate medication should be used? It's either A, oral metoprolol plus sodium nitroprusside, esmolol, nicardipine for C, and then D, labetalol. I'll give you guys a couple seconds to go over that as well, so you can go back and refer to the case, and then we'll go over the correct answer choice. Okay, so the correct answer choice is D, labetalol, and the reason for that is one, labetalol works twofold goals, such as decreasing the blood pressure and controlling the heart rate as well. Compared to you can use esmolol by itself or nicardipine. You guys want to combine those medications. And choice A would actually work if it wasn't oral metoprolol, it was IV, because you want a quick onset of action. So here's some other hypertensive emergencies. Other ones include acute flash pulmonary edema, which is simply respiratory distress related to the rapid accumulation of fluid within the lungs secondary to elevated cardiac filling pressure. The drug of choice is actually nitroglycerin. Just some things to know, some clinical pearls or adverse effects. It causes a flushing, headache, and erythema, and it requires frequent dosing due to tachyphylaxis. For preeclampsia and eclampsia, so that's pretty much occurs after 20 weeks of gestation with either proteinuria or other severe features. And usually the blood pressure is greater than 140/90 for that as well. And it's also actually, eclampsia on the other hand, it's kind of like defined by the presence of new onset grand mal seizures in women with preeclampsia as well. So if they have preeclampsia, they're more likely going to have seizures as well. So the drugs of choice are labetalol, hydralazine, or nifedipine. For nifedipine, you want to use oral nifedipine. You never want to use IV nifedipine due to sudden uncontrolled and severe reduction in blood pressure, which leads to cerebral, renal, and MI ischemic events, and this can actually lead to fatal outcomes. So a couple things to be aware, that there's more maternal palpitations and tachycardia with hydralazine versus labetalol, more neonatal bradycardia and hypertension with labetalol versus hydralazine as well. And then the prospective studies also show no difference of blood pressure attainment goals between labetalol or hydralazine, so you can use either or. Just depends what you're looking for based on the clinical pearls and adverse effects. For this sympathetic overload, such as the pheochromocytoma crisis or opioid-induced hypertensive crisis, you can drug of choice for pheochromocytoma is phentolamine, and then for the opioid-induced hypertensive crisis, you can use phentolamine plus a benzodiazepine, or you can actually use alpha blockers as well if you don't have the phentolamine on hand. Beta blocker should be initiated prior to surgery after several days of alpha blocker therapy if they have a pheochromocytoma crisis as well. And another one is acute left ventricular failure. The drug of choice is enalapril, and this medication requires no hepatic activation, and it's 10 to 20 times more potent than captopril. So based on that, you kind of want to avoid ACS due to the increased risk of myocardial infarction or cerebral vascular event if there's an excess fall of blood pressure occurs. So here's a treatment algorithm. Kind of just remade it from the guidelines. So pretty much if you have normal blood pressure less than 120/80, you just kind of want to promote optimal lifestyle habits and just reassess every year. For elevated blood pressure, you kind of want to use non-pharm therapy and then reassess into 3 to 6 months whether if the blood pressure is increased or if it's gotten lower and whether they need to be added on a blood pressure lowering medication. And then here's the other side of the algorithm. So if they have stage 1 hypertension, you kind of want to screen, see if they have either ASCVD or if their risk is greater than or equal to 10%. If it's not, you kind of just want to use non-pharm therapy, see if they can get it lower to within the elevated or even normal range, and then reassess into in 3 to 6 months. And if it's they do actually have if they have an ASCVD or if the risk is greater than 10%, you want to use non-pharm therapy and blood pressure therapy as well, and then reassess in a month. For stage 2, you obviously use non-pharm therapy, and then you want to start with 2 blood pressure lowering medications. And once again, that's very different from the previous guidelines where they recommend 1. You want to start with 2 right away, and then reassess in a month. And then you kind of see if they met their blood pressure goals or not. If they did, great. Reassess in 3 to 6 months. If not, you kind of want to assess and see if they're adherent to the medications or not. And then you can consider intensifying therapy as well. So learning question number 7. DJ is a 63-year-old African-American male who is present for routine checkup at the clinic. His blood pressure readings are 136/78 and 138/78 respectively. And his ASCVD risk score is 6.2%. What is the appropriate treatment for this patient? So A is amlodipine 5 milligrams every day. B is lifestyle modifications. C is amlodipine 5 milligrams and hydrochlorothiazide 12.5 milligrams every day. Or D, lisinopril 10 milligrams every day. I'll give you guys time to go over that. Okay, so the correct answer choice is B. The reasons why it's B, if you go back to the algorithm, the patient's considered stage 1 hypertension. However, he doesn't have any risk factors for ASCVD. He doesn't have any ASCVD risk factors, and his score is actually 6.2%. So the algorithm and the guidelines recommend actually starting with lifestyle modifications first and then reassessing within 3 to 6 months, see if they met their goal or whether they need to be started on any antihypertensive medications. So here's something that's more applicable to you guys, the hypertensive crisis algorithm. So once again, the systolic blood pressure is greater than 180/120, and you kind of want to see if they have target organ damage. We'll go over the target organ damage. So if they do, obviously it's an emergency, you admit to the ICU. Then you kind of want to screen, see whether they have these conditions, either aortic dissection, severe preeclampsia or eclampsia, or pheochromocytoma crisis. So you want to reduce the systolic blood pressure less than 140 within the first hour, unless it's aortic dissection, which is less than 120. And if they don't, you kind of just, like I mentioned before, reduce blood pressure by a max of 25% over the first hour, then 160 to 100 to 110 over the next 2 to 6 hours, then back to normal within the next 24 to 48 hours. And if they don't have any target organ damage, you simply just reinstitute or intensify antihypertensive oral therapy for them, kind of reassess. So learning question number 8 is GQ's 62-year-old African-American male who presents to the ER with a blood pressure of 214/112. He has right-sided facial droop, trouble speaking, and altered mental status. It was discovered that he was down for 6 hours and is out of the window for TPA. When should GQ's blood pressure be lowered? So it's either A, greater than 185/110, greater than 220/120, C, less than 180/105, or D, 210/110. I'll give you guys time to think about that as well. Okay, so the correct answer choice is B, greater than 220/110. The AHA guidelines recommend actually not decreasing the blood pressure unless it goes to that point. And then you actually don't want to restart. If it stays under 220/110, you kind of just want the blood. Do not restart blood pressure. It's not effective to start blood pressure medications within the first 48 to 72 hours. So you kind of want to wait after that before reinstituting blood pressure medications, just so you get more cerebral perfusion. So here's some oral medications we have on formulary. I'm not going to go over this to bore you guys. It's just it might be something helpful when patients are first admitted to the hospital. And here are the IV parenteral medications we have on formulary. Just a couple things I want to mention. I'm not going to read through these again. We have pretty much every single IV medication I discussed on formulary with the exception of phenoldiprem. And that's pretty much it. And then just be aware of clozapine only it's restricted to the ICU and the ER as well. So learning question 9. TJ is a 72-year-old white female. Presents with the ER with a blood pressure of 220/114. TJ has a left-sided facial droop and altered mental status that began about 1 hour ago, according to her son. Patient's unable to follow commands. Patient's diagnosed with right-sided ischemic stroke and is a candidate for TPA. What should her blood pressure be lowered to before initiation of alteplase? So it's A, less than 185/110. B, less than 185/105. C, less than 180/110. Or D, less than 180/105. I'll give you guys time to go over that, and then we'll go over the correct answer choice. Okay, so the correct answer choice is actually A. It's less than 185/110. That's just a recommendation straight from the guidelines. Just for practical reasons, some actually institutions choose to actually lower the blood pressure to less than 180/105 before initiating TPA. So if the blood pressure were to increase, they don't have to stop the administration of it. Just something to be aware of from the practicality standpoint. And finally, learning question number 10. What is the blood pressure for her goal after TPA administration? It's either A, less than 185/110, B, less than 185/105, C, less than 180/110, or D, less than 180/105. I'll give you guys time to go over to the previous case and then come up with your answer choice. Okay, so the correct answer choice in this situation is D, less than 180/105. And that's just direct recommendation by the guidelines. And here's just a therapeutic interchange chart I made just so it's helpful for you guys. I'm going to briefly go over it real quick. So if there's an ACE inhibitor that's ordered, you can pretty much switch it all to lisinopril. If it's ARBs, you can go to losartan. For timolol, you can switch to propanolol. For biastolic, you can do bisoprolol. If it's betaxol, you can do atenolol, even though atenolol is not a really good drug to be used because of its long half-life. It's actually not recommended for outpatient settings either. Pindolol, you can do carvedilol, and then all other DHP calcium channel blockers, you want to use amlodipine. So I just wanted to acknowledge Mitesh and Nate. I want to thank them for all their help. They've been very helpful throughout. And any questions at all, if you have any questions, feel free to email me at sandres.aodish@wayne.edu. That's sandres.aodish@wayne.edu. Thank you for listening to my presentation, and I hope you all have a great day.